everybody. Thank you so much for joining us this evening, and welcome to our Autism Exploration Series. I'm Dr. Emily Stampone, the Clinical Director of Field Services here at Verbal Beginnings. Verbal Beginnings' mission is to change lives for both our clients, families, and of course, our professionals. And we do that through our pledge of care, our promise to you to provide effective treatment through compassionate care. We also strive to achieve our mission through our core values. One of our core values is education, teaching families valuable ways to work with your child. And that's why we decided to start these series. Additionally, you'll see on the bottom of the screen the seal of the Behavior Health Center of Excellence and the seal from the Autism Commission on Quality. Both of these seals represent the hard work and focus that we place to ensure that Verbal Beginnings is providing quality care through the highest of standards. Next slide, please. I also wanted to take this opportunity to introduce you to the services that we offer here at Verbal Beginnings. In addition to our in-home and center-based ABA services, we also offer center-based comprehensive services, feeding therapy, and social skills programming. Additionally, we encourage you to participate with us today throughout the presentation by using the Q&A feature found at the bottom of your screen. We also offer closed captioning during this recording, which you can access by navigating to the bottom of your Zoom screen and clicking the closed captioning button. Okay, without further ado, I'd like to introduce you to our presenter for the evening, Ben Sarcia.
Hi, everybody. Thanks, Emily. I appreciate your send off there. So this presentation is about food selectivity and refusal, and I'll just disclose up front that Verbal Beginnings is an autism services provider, but pretty much everything we're going to talk about here tonight is applicable to feeding issues in general, and it's not specific to autism per se. Just a little bit about me. I'm a board-certified behavior analyst. I got my first experience with applied behavior analysis and addressing feeding issues when I was a graduate intern back in 2009. After that, I became a behavior analyst, and I worked in the feeding program at Kennedy Krieger before moving on and getting started with the Healthy Beginnings program. And then I am also a doctoral student in the applied behavior analysis program at the Chicago School. So what is beyond typical pickiness? Because pickiness is normal. So this would be only eating a few foods, refusing foods of certain textures, colors, brands. I know during COVID, this was tough because we got calls when the supply chain issues started where a parent would call and say, my child only eats the Tyson fresh dinosaur chicken nuggets and we can't get them. And what do we do? So brand is important. It is important to consider, too, that everyone has preferences, and this is okay. But if it gets to the point where, the child is really limited in what they'll eat, or it's hard to travel outside of the home, then that's where it's overly picky. We'll talk more about that. And then, of course, if introducing new foods or changing the plate or changing the type of cup, or where dinner is served, if that results in, a tantrum or some kind of problem behavior, that's something we want to look into. Refusing to feed oneself. We meet a lot of kids in clinic who, are 5 or 6 years old, but have never actually fed themselves, and they've relied on a caregiver, and they just haven't progressed to doing self-feeding. And then certainly, concerns about growth, failure to thrive, if the child's not eating or drinking enough to gain weight, maintain weight, is losing weight, is having issue with malnourishment, or certain nutritional deficiencies, dehydration. If meals require a lot of toys or videos, if the child will not sit without being able to watch a video, that's something to look into as well and work on. Binging or grazing on snacks or preferred foods. The grazing can make it really difficult to kind of address. So that's something I encourage families to work on as soon as possible if your child is a grazer. And then, of course, sometimes this is a skill issue and sometimes it's a behavior issue where it's we see the child swallowing foods whole or just not chewing the food or not chewing the food well enough. So different types of food and liquid selectivity that we look at are texture, food group, color, brand. I think most of the kids I meet, parents come in and say, well, my child eats a few fruits, no vegetables, and they eat McDonald's chicken nuggets. Um, the setting where meals occur, that can be important to consider as well. Recently, I met a lot of kids who just won't eat at school, and then when they get home, they're starving. So that can really impact education, of course. I'm not going to spend a lot of time on this slide, but avoidant restrictive food intake disorder is a diagnosis specific to feeding that's in the DSM, the Diagnostic and Statistical Manual, that basically describes a feeding issue that isn't related to culture or a lack of food availability, and that isn't an eating disorder such as anorexia or bulimia, as those are typically have different psychological components or body image components that you would not find with RFID. So relating this specifically to autism spectrum disorder and the diagnosis for that disorder would be an insistence on sameness, an inflexible adherence to routines, ritualized patterns of behavior, difficulty coping with change. So the packaging, they changed the color of the top on the fruit pouch and now the child won't eat it, or they're throwing it across the room, or they're sobbing because it's different and it's not the way they're used to. As far as prevalence goes, we know that as many as 80% of children with a developmental disability have some kind of disruptive eating pattern of behavior. And at one point for autism, it was part of the diagnosis, though we now know not every child, of course, with autism has a feeding issue, but it is incredibly common. At our Verbal Beginnings Center in Columbia, Maryland, for the early intervention program, 76% of the children also came through our feeding program. It's that common. So nutrition, and if you were with us last year, I presented a whole webinar on nutrition. So that might be one we could revisit again in the future. I like that one. But just some interesting things here about how nutrition is impacted by food selectivity and a poor diet. And kind of the basic summary of the nutritional research is that the intake of vitamins and nutrients is typically far lower than peers without an autism diagnosis. So that's really something to consider. And this can impact growth and development and produce certain conditions if there's a nutritional deficiency. So it's an important area to consider, is making sure that diet is good. So why is it important to intervene? In my experience, what I found is that, especially parents of younger children, so maybe between the ages of 2 and 4, that getting that diagnosis is hard, right? Like there's a lot to consider. There's a lot to consider when you're pursuing therapies. And I'm sure, if you have a pediatrician or a developmental pediatrician who's saying, you need speech and OT and ABA, and they might be saying 40 hours a week of ABA is normal. And there might be school involved as well, right? And perhaps PT. So adding feeding therapy on top can be challenging when trying to prioritize, what's something that we want to intervene on first and try and help. But what we know too is that we have a lot of kids that enter our early intervention program, for example, and have such poor diets, and that's really impacted their nutrition, or they're even going to the bathroom, that there's a certain level of discomfort that's related to the poor diet that then impacts long-term health, but also learning. So this is all important to consider. The bowel habits, I feel like, is the one I hear most, and how often I meet children who have a really limited diet that are constipated, and how much that constipation can impact behavior throughout the day, which makes sense if the child is uncomfortable, or how that can impact sleep. Years and years ago, when the Healthy Beginnings program was new, we worked with a child who had a very limited diet and had really a difficult time with constipation. And I always use this as an example of a study that I wish we had conducted, because his classroom was next to my office. So I heard them for weeks, trying to teach him to just imitate some words, because they were working on communication in the classroom. And once he started our feeding program, his nutrition improved tremendously, and he started pooping and he started sleeping. And then after that, he started talking more. So while it's certainly not a guarantee, that example stands out to me as what a cool outcome for that kid, that he felt better and was more able to learn in the classroom, and that really impacted his life. We know too that feeding issues can impact the family unit and siblings. We've met families that don't take vacations. I met a family who recently were taking a trip and the child only eats a certain kind of macaroni and cheese, and that was the one food that he would eat before he started working with us. So the family had to book a hotel suite so that they would be able to make it. Whereas, normally they would have just booked a regular hotel room. Quality of life is important to consider too, of course. I think we meet a lot of children who have difficulty, just even tolerating looking at a new food or smelling a new food. But it produces anxiety and difficulty for caregivers, and that can be really hard to manage from day to day. And mealtime becomes a point of anxiety. So I think being able to help address that has certainly been a mission of mine. So, what does behavior assessment look like when it comes to feeding issues? We want to consider any kind of skill issue, of course. Is it that the child cannot eat or drink? Um, this would be like if there was a swallowing disorder or maybe something that caregivers didn't even know about. We had a child in the program years ago that had such a limited diet. It wasn't until we actually started teaching her to eat new foods that we discovered she had a swallowing issue and that we needed to refer her out to an appropriate provider to address that so that we could safely and effectively address the behavior once that issue was taken care of. So that's really important. Oral motor skills are something that we consider as well. I mentioned chewing earlier being a potential issue, and perhaps a reason for a child that has an advanced texture, and that's where oftentimes we might work with a speech and language pathologist to kind of coordinate what's the best kind of protocol that we can develop to teach the child to effectively chew and do it in a safe manner. Um, I know for me in my program, since we don't have a medical doctor on staff, we require all of our children to have approval from a at least their pediatrician, but sometimes a specialist is involved. So that might be a child that's having problems with reflux. We might say, you need to see a gastroenterologist before we can start behavior treatment, because we want to make sure that by teaching them to eat new foods and introducing new foods to their diet, that we're not going to make them more uncomfortable, that we're not going to give them something that's going to upset their stomach and presumably have the child dislike eating more than they might already. So then we get to if the child does not eat or drink. So it's not a skill problem, but it's a performance issue. I can do it, but I won't do it. I can eat vegetables. There's no skill problem that's keeping me from eating vegetables. I just won't. And so as a behavior analyst, we always consider how the child's environment has shaped up this behavior and kind of made it happen. And this is where I feel like I meet families during the very first appointment with me, and it's usually mom or dad saying like, well, I did this. And, that may be true. Um, but I think normalizing that, right? Like that's any parent. There's just so many situations where you're like, oh, I know this is not the right move, but in the moment, I need you to eat something. And that's where we meet kids who only eat chips and donuts because they are smart and they have figured out, if I do this, if I cry, if I throw this on the floor, like you name it, that'll convince mom and dad to give me what I want. We'll talk a little more about that later. Um, so then, of course, when we're assessing, we want to consider, what's the refusal like? Is it politely saying no? Is the child sitting there and ignoring? Is the child just kind of walking away? Which may be concerning too if there's a certain safety issue. I had a child once who tried to run out the front door in response to a vegetable, so that was concerning. Then there's more moderate issues. So the child's eliminated at least one food group. And where I distinguish this from a mild issue is, the mild is more pickiness. The child might not eat enough foods, but they're maintaining a healthy weight. They're growing. They're eating at least, one or two foods from each category of food. And then things become more severe when there's malnourishment, dehydration, if there's a feeding tube involved, if the pediatrician has given a label of failure to thrive. So that label, if you're not familiar with it, is common for children who are not growing or they're losing weight. They're not achieving their milestones as far as growth is concerned. And that's where we might also see multiple food groups have been eliminated. In that example, or that category rather, we might also see that the child is really gravitating towards only eating a few things, or they're only drinking Pediasure. and that's how they're getting calories from. Eliminating foods that were previously eaten. Food jags, if you're not familiar with that, that is a pattern of behavior where the child, or adult for that matter, might eat a food for a period of days or weeks or even months, and then just one day completely refuse it without warning. And oftentimes when I have parents who say, yeah, my kid was eating strawberries, they ate them at every meal for 3 weeks straight, and then I brought out the strawberries on Saturday morning and they wouldn't touch them and they cried. Um, and it's one of those where, we might never be able to explain why that happened. Um, but it's frustrating because so often the parent says to me, then it becomes a guessing game of, all right, well, if you won't eat the strawberries now, what are you going to eat? Um, and that can get really difficult. So some misconceptions about feeding therapy. Being a behavior analyst, I'll open it with that ABA cannot be used for mealtime behaviors. This is very inaccurate. We actually have a huge body of empirical literature, significantly more than any other disciplines that work with feeding issues. And I'll talk about how other approaches address a feeding issue in a moment here. But ABA is a very well-researched practice. We have had some insurance companies, though I should probably edit this slide because most of our insurance companies really recognize what we do as ABA providers when we call to ask for feeding or we submit a treatment plan request, which is really cool, actually, because when I started at Verbal Beginnings with this program years ago, that was harder. Um, Certainly, skill deficits are an area where there have been questions, and the reality is that ABA works on skill and performance deficits all the time. Autism or not, any kind of just general issues in population, even I was more recently putting together a paper on traffic and how applied behavior analysis has been applied to address speeding behavior and reduce vehicle accidents. So there's a lot of cool applications of behavior analysis. But certainly in the feeding world, that's where we look at developing skills like chewing and, using utensils, drinking from a cup, learning to close your lips effectively around the cup and not spill or have all the liquid leak out of your lips when drinking from a cup. I hear this misconception a lot from parents who have waited. So their child might be, 8 or 9 years old and has had years of history of a feeding issue, and the pediatrician has said, they'll grow out of it, or a family member has said, well, if you wait, they'll eat, or my child will get hungry enough, maybe. And I think the record I heard was I had a mom who told me that she waited 3 days before she finally gave in. The child was not willing to eat. What she was offering. So that's kind of scary. We know certainly that rigidity is a feature of ASD. It's also hard to talk our way out of the problem. And I put this one, and I think primarily because, by the time a family gets to me, they've already tried, they've tried bribery, they've tried negotiating, bargaining. Um, I had a nonverbal child once who was seeing a psychologist, and I still don't understand how that worked. It didn't help him. But so we always try and consider the child's verbal behavior skills and what their abilities are. I can tell you for me, when I am implementing a protocol, which is kind of the structured set of rules that we develop for the child when they enter the program, that we always tell them what the rule is before we start the meal. So if the rule is, when you take your bite of a green bean, we'll get to play with Legos for a little bit. That's always something we want to tell the child up front, whether we think that the child can understand what we're telling them or not. ABA isn't bribery. And actually, I had a family bring this up with me today. So I think people sometimes get confused with the difference between reinforcement and a bribe. And the reality is that reinforcement is planned. So if you work a job and you get a paycheck every 2 weeks, that's accessing reinforcement. Bribery would be something bad has happened and I'm trying to change the behavior. So thinking about, eating blueberries, the child has thrown the blueberries on the floor and the parent says, okay, fine, I'll give you a piece of chocolate if you eat the blueberries. And where bribery is certainly problematic is that in that example I gave you, the child has just learned, okay, the next time I want chocolate, I'm going to throw the food on the floor. So reinforcement is always planned and considered. And it's important to have an exit strategy for reinforcement as well. Misconception of force feeding. So foods that we're including in meals, the bite size, the amount of the food that we're giving, prompting, these are all things that are planned prior to beginning the intervention. There are some disturbing videos of force feeding on YouTube. And so often what we see is these happen in countries where there are less medical resources and they don't have access to things like feeding tubes or Pediasure for children that are truly malnourished. Um, they're difficult to watch, and I think we are lucky, at least where I live, that we have access to so many healthcare options, including behavior analysis, to be able to address a feeding issue before one would get to that point that they didn't know what else to do. Um, I like to plan for choice, and I included this here as well because when I first started in feeding, it wasn't something that we gave as much credit to, or at least we didn't talk about it as much. And now I think I think we're just giving our children so many more options. So like if I have a child that comes into the clinic that won't eat any vegetables, I usually ask the parent to send in 2 or 3 vegetables so that we can allow the child the opportunity to pick which one they want to try. Um, and that's helpful. We do have some kids that just don't want to pick at all, so that's something to consider as well. But I like offering a choice. So alternatives to ABA, because certainly ABA is not the only game in town. But so occupational therapy. So often, they might work on oral motor skills and occupational therapists. They might recommend blending foods together. So, for example, you might be able to blend in vegetables, which is not necessarily the greatest option. Because so often kids might, eat a blended vegetable it's blended in with the food that they do like, and so they don't know that the vegetable is there. It's a good option for getting nutrition in, and better than nothing, right? If you don't have another choice, but it's not necessarily a good long-term option. Occupational therapists also consult on postural and any kind of seating recommendations if there's something kind of specific. I know at Kennedy Krieger, they have a whole seating clinic and all kinds of different options. Really great option for assessment for children, for example, like that have certain like spinal issues or have difficulty, sitting at a regular table, or muscle tone issues. Texture manipulation might be an intervention recommended. Co-treatments with the BCBA. I know when I was at Kennedy, I liked doing these a lot because I got to learn a lot more about occupational therapy that I hadn't previously been exposed to. Desensitization is an interesting treatment. It's not necessarily been proven to be all that effective in increasing acceptance of new foods among children with autism. But what we've seen in my clinic is that children who have gone through desensitization programs are more tolerant of, touching the food and touching it to their mouth. And what we see is that when we say, all right, here's the plan, we're going to eat 3 bites of the carrot today, that we see that they're actually less upset because they're more used to the food and being near the food and smelling the food and touching the food. So there might be some value to that. Sensory diets are common as well. There's not really any research to support the application of these, and this is where I caution parents, because I've seen people spend a lot of money on vibrating brushes and things that are supposed to stimulate the mouth or wake up the tongue or make the tongue, move better. And I think oftentimes when I see these, I look at a kid and I go, well, I don't see you have any problem moving your tongue, so that doesn't seem like the issue. The sequential oral sensory approach is another option out there. It's a type of desensitization. It's a very popular program, but the research is very limited, and the best article we have shows that it's not a terribly effective approach when compared to ABA. Speech and language pathologists, really important as well. Oral motor skills, especially if you have a child with a swallowing issue, definitely involving an SLP is really critical. I should mention too that for OT and speech, and for ABA as well, not everybody who's a speech therapist is trained in feeding, and the same goes for occupational therapy, and the same is definitely true of ABA. So if you are working with any of these kind of providers on feeding, you want to make sure that they did receive supervised training, and it's not just something they decided they wanted to do one day or kind of read some articles about and felt competent that they could do it. Texture manipulation. MBSS is a modified barium swallow study. So sometimes my role as a behavior analyst is to increase the child's acceptance of liquids or barium or drinking from a cup so that they can go and receive this kind of study to ensure that they are a safe oral feeder. So sometimes that's the step that's first before we even work on increasing food consumption. A different assessment of oral structures, SOS again. And then there's tools and utensils and cups and things like that that have been recommended. Some of that is controversial because there's a lot of products out there that are clearly invented to make a company money and not necessarily provide any kind of practical intervention, but they look good and they sell. So that's reinforcing to those companies, of course. And then psychologists, counselors, social workers. I know here in Maryland we have licensed clinical social workers. So these therapists might work on addressing feeding issues via discussion or exposure therapy. I think oftentimes the children we work with so often wouldn't be able to express if they had anxiety, though they might. Or if there was a specific phobia, or if they have truly learned, hey, I throw the food on the floor, that I'm going to get the dinner that I want. So that's where, I assert that the question of, do these interventions address the function of food refusal? And so often the answer is no, because the function has never been considered. And so while these are therapies that are important and therapies that I co-treat with, and that's of value, it's really important. It's the most important to produce a functional treatment by considering what exactly is the function, which I believe is my next slide. So looking at the four functions of behavior that behavior analysts have accepted and that are very well researched. So attention. This might be a reprimand, it might be coaxing, comforting, it could be encouraging the child. A really clear example of this that I use is that I had a 4-year-old girl, and she had 4 siblings. And she knew that if she refused to eat, that her mom was going to sit next to her at dinner time and feed her. So over time, she just kept engaging in refusal to eat, and her mom kept feeding her because that's a natural parent behavior, right? So then it got to the point where it was really problematic, and we had to come up with a strategy to address that. And so ultimately, she got lots of attention when she ate, and if somebody had to help her eat, she didn't get as much. Escape is the biggest. And I'm assuming that for parents, caregivers attending this webinar, that's probably not a surprise, but so often it's, hey, I put the food in front of my child, they want nothing to do with it, or they're yelling at me, or they might be hitting or scratching or something, some kind of inappropriate behavior that's not acceptable. But to get to the point where the parent says, okay, fine, you don't have to eat it. And over time, that behavior is reinforced, right? The child learns the food I don't want to eat goes away, or I get the type of cup that I want, or I get the toy that I want, which is also a function. So access to desired things, so food, liquid, toys, videos. I had a child years ago who had figured out that the iPad had been taken away and they were no longer allowed to have the iPad, but they had figured out if they refused to eat, that their parents would resort to the iPad because they knew what a powerful reinforcer that was. But eventually the child got to the point where they just wouldn't eat anything without being able to play with the iPad or watch videos. And then there's also automatic functions, and these are really challenging to assess in the mealtime context. So automatic is any kind of internal, so nobody else has to do anything. So an example of this might be chewing. So nobody else is reinforcing my behavior of chewing. If I eat a food, I'm doing that for me. That feels good. It's something I need to do to safely and effectively eat food, so I'm going to keep doing that. But also automatic or kind of sensory issues that I consider are, pain or discomfort, or sometimes it's food temperature. As another example, I have many examples. I had a child just recently won't eat anything in school because the thermos that the lunch is sent in doesn't keep it hot enough, and the child insists on having super hot food to eat. So that's that's a sensory consideration. So ultimately, these functions apply, and I won't say that they all apply to every child. It might be that the child is just simply trying to escape. None of these other functions apply. They just simply want to escape the demand to eat a certain food. Um, so these functions apply. They've been reinforced over and over again, and they're going to continue to occur until a new plan of action um, is developed. Or sometimes, the child may mature and, kind of naturally be more adventurous to eating new foods. Um, I always share that when that happens, I don't really ever know because I meet the children that they just haven't made progress in trying new foods on their own, and caregivers are left to the point where they just don't know what to do. So reinforcement. Not being too technical here, but the definition of reinforcement, of positive reinforcement, is anything that's added, something that one likes, or removed is negative reinforcement, something that one doesn't like, in order to increase a behavior. So when we think about feeding, um, if the child is refusing to eat and they're given chocolate, that serves as a reinforcer to continue to refuse. But if they're refusing to eat and the blueberries now go away, that would be negative reinforcement because it's something they don't want is being taken away. And it's teaching the child, hey, every time I engage in whatever that behavior it was, if it was pushing the plate across the table, if it was dumping it on the floor, if it was squishing the blueberries and throwing them at the dog, like you name it, that's going to reinforce those maladaptive behaviors if the parent then says, okay, you don't have to eat them after all. So that's where, as behavior analysts, we look at the behaviors that we want to increase. So taking bites and of a variety of food, maybe a variety of food textures, swallowing those bites, because we definitely have children who learn to accept food, but then they hold it in their cheeks. Which is always super fun, right? Because we're sitting there playing like, okay, you took your bite, you earned your reward. Let's play, let's build the Legos, or let's build the tower, or let's play with the doll. And the kid's like, God, chipmunk cheeks because they're holding, and we kind of have to plan for safety about what we're going to do next if the child isn't swallowing their bites. But also working on self-feeding and skills like drinking from a cup. I meet a lot of 8-year-olds that have never progressed from drinking milk from the baby bottle, and that can be a really challenging um, behavior to work on when we finally say, okay, it's time to get rid of the baby bottle and we need to drink from a cup. So problems with reinforcement and ASD specifically is that for many kids, not all, but there's a lack of options. So a really clear example for me is that I had a child who was traveling about 45 minutes to come to our clinic and was getting the iPad in the car. And the parent insisted that the iPad was the only thing that the child was interested in, that's the only thing that would work during feeding therapy. Well, it didn't work because she would get it in the car on the way to the clinic and she would get it on the car on the way home. So she didn't need to eat in order to have it. And it wasn't until I convinced the parents that they were wasting their time making this drive because she wasn't making progress that they agreed to limit access to the iPad to only to meal times. And that's when we saw progress start to happen. So something you can consider at home as well. Um, Competing reinforcers, of course, the biggest one usually is escape. And I'm going to I have another slide that touches on this, but just simply getting out of eating or getting out away from the table or not being anywhere near the green beans is often can be more valuable to the individual than actually, getting a toy or a video or something like that. So that's something we have to consider. And sometimes it's a real challenge to be able to effectively address the behavior. It might take a little more time than we hope for. Self-stimulatory behavior too can compete. We have some kids where we're waiting for them to take the bite and kind of waiting and allowing them to do it on their own terms, but we've also promised them, a fun toy or that we get to go out in the playground or do something really fun. And they're just as happy to sit there and stim until it's time to leave. So that's frustrating from a therapeutic standpoint. Um, and then, of course, at home, distractions can be difficult. So siblings, pets, the phone, if the TV's on the background, I think that's the biggest distraction I hear from parents is how often, a TV might be really just kind of disrupting the meal or distracting the child from focusing on eating. And that's where we might see the lack of self-feeding behavior emerge because the child is not paying attention to their meal. Satiation is important to consider as well. So like thinking about the grazing that I mentioned in the beginning of this presentation, um, if the child has had access throughout their day to snacks or things that they really like to eat, and then the parent says, okay, it's time to sit down and try broccoli, and the kid's not hungry, like that's just one less motivation that you have in working in your favor there. So you want to make sure that when you're introducing new foods, that your child should be hungry. And then of course, I pick on the iPad here because it's probably one of my least favorite things when it comes to feeding therapy, because so often it's the option of choice is reported by parents, but it's just not motivating enough. And as I mentioned earlier, it's because so many of our kids that this is their leisure activity and they get to play with it outside of meals. So the motivation to earn it for eating new foods is typically pretty low. Um, Research also tells us that reinforcement is rarely effective on its own when it comes to problematic mealtime behavior. So this relates directly back to what I was saying about the motivation to escape is greater than that toy or that video or video game or access to the playground. And that's where ABA is very different from other approaches, is that we have a plan for prompting and for waiting. We have a very specific plan. We plan for safety. We're prepared, and that's why ABA is incredibly effective at addressing challenging mealtime behavior and increasing the kind of behaviors that we want to see. So the specific approaches that we use are called non-removal of the spoon or the cup. And so essentially the feeder is being patient. We've made a promise of some kind of reinforcement. That's something we always do because we know, okay, the food is not reinforcing on its own. It's not interesting enough. It's not motivating enough. Otherwise the child would eat it and they would never make it to our feeding clinic. So this is where we pair that with this strategy of waiting. So that's where if I'm the feeder, I'm just holding the spoon and waiting. I typically, depending on the child's skill level, I give them the opportunity to take the bite on their own and pick up the spoon or pick up the piece of food and put it in their mouth. But if they don't, I hold it and I keep it near their lip and I just kind of wait. Um, the potential temporary side effect of this is an increased emotional response from some children. And this is usually short term, but I think what we see is for a lot of kids that a tantrum may emerge. That, whereas before I could get rid of the food or mom and dad have learned to just give up, and that's pretty easy to make the non-preferred food go away. Um, or the new food, whatever you want to call it. And now somebody is sitting here and we're just waiting. And that's where we might see more kind of challenging behaviors emerge. One strategy that we have to address that is that we make things short. So we might do like 10 minutes at a time and then take a break and then try again later. But the idea being that, we wouldn't want to force a child to sit in a room for an hour, and especially if they were, really upset. We want to take that time, that break to kind of calm down. So again, something you can try at home, but we always use a timer and we let the timer signal when we're done. So that way it's not me as a therapist saying, okay, I give up, this didn't work. And that's where that choice also comes in, like I mentioned earlier, offering the child an option of vegetables to try rather than saying, here's the broccoli, this is what we're going to do. I caution parents, as a caregiver, if the child is upset, and I think the child has every right to be upset if they are, but this can be emotionally difficult for parents too. And if you're there and kind of observing the appointment and how it goes, we always encourage parents, to kind of be ready for that, but that um, most of our kids when they leave the room are just so excited to like leave and be done that they kind of forget about it, and it's not a difficult thing. So that's where we encourage parents, capitalize on the good things that you saw happen. But it's important to be ready that if you're upset by your child becoming upset, that this can be hard. But so often the result of working through those challenging behaviors is so positive, and it avoids um, really difficult long-term discomfort that I've seen happen to kids that just didn't get the effective intervention when they should have. That is far worse than kind of going through and working through some challenging behavior to learn how to eat new foods or to gain new skills. We have some kids who spit out foods, and that's where we might represent a new bite of that food to teach them that, spitting the food onto the floor is not acceptable. Um, we also don't attend to challenging behaviors. And so in that sense, I say that, if the child is, well, so often what I see is, if the child's throwing the spoon, across the room and the parent says don't do that, that can actually be reinforcing that behavior or making that behavior more likely to occur. If the child likes the attention that they're getting from that by engaging in that behavior, they're going to keep doing it. And so that's why as therapists, we keep our attention until the child is doing what they're supposed to be doing, which is taking their bites, feeding themselves, chewing, swallowing, taking their drinks. And that also is what makes it fun. We have some kids who, at the sight of new food, gag or throw up, and it's really important that if there's not medically something wrong with the child, that you continue to work through those behaviors. Just because we have met a number of times extreme cases where the child has learned to throw up in order to get out of eating. And it's really problematic and it's challenging to work through. So that's where if a child throws up or they're not truly sick, we clean it up and encourage the child and really try again. And so often we see success. Um, and then, of course, prompting appropriate behavior, providing models for appropriate eating, to address, any kind of refusal or bites that are packed in the cheek. Um, some kids we have, we might use a brush if they are chronically keeping bites in their cheeks. We might use a soft bristled brush to kind of push and move the food onto their tongue to help them swallow. And then, of course, parent training is the most important component. So in my program, we do appointments 5 days per week um, for there's different prescription levels depending on the child's need. But parents have to be involved throughout the process. So most of our children are in our program between 4 and 8 weeks. And during our initial weeks of therapy, we set it up so that parents can observe. They certainly do not have to be present for every single appointment, of course. But then usually during the last 2 weeks is where we have parents entering the room and learning how to implement the same kind of rules so that they can then apply those rules at home. What we know is that the child has actually, and I talked about this earlier, but the child has trained the parent to behave a certain way so that the child can get what they want or get out of eating what they don't want. And so that's behavior that we have to undo and that we have to change. And that's where it can be really helpful that therapists conduct initial appointments because that person's not going to have any kind of history with the child, whereas parents do. They have a different history. I mean, I get it. I have two of my own children, and I know that they act differently with me than they do with their teachers at school. So that's where we utilize our therapist to come up with a plan, teach it to the child, but then to teach it to the parent. Our program is certainly not successful if the parents can't apply the same strategies at home, but our goal is to develop a plan as well that the parent doesn't have to rely on forever. So there is some time and effort involved, but our parents report, after discharge from our intensive program that oftentimes, a period of weeks or maybe a few months that they can start kind of relaxing on the rules because the child starts to like more foods and are more willing to eat them, which is always really cool. So when thinking about if you're ready, because it's not necessarily the easiest intervention, you want to consider all the kind of psychological factors, medical, dental, make sure your child is healthy enough that you wouldn't want to start a therapy program and have to pause it or have to stop it because the child wasn't actually well enough. So that's something that we take very seriously. And I think considering kind of life events as well is important. I always tell families like if you have a newborn baby at home, like don't do the program until your child is sleeping well enough through the night because we're going to ask you for your other child to do work as far as mealtime goes, and how feedings with newborns are. There can be a lot there. But also, I've seen families that weren't ready, that should have prioritized feeding, and this is where it's kind of hard, because we've got kids that are older or really strong or just refuse to exit the car. And that can be really hard to challenging when we can't get them inside the building to even kind of come up with a plan to learn how to eat new foods. We also know from the research that delaying intervention can impact the nutritional state of other children in the home. There's consistent research that shows that meals are impacted by and influenced by the child who is selective, and that oftentimes the nutritional diversity of family meals are influenced, and that's problematic. The availability of the caregiver is important too, as I just emphasized to you that that training piece is really, really critical. So wrapping up here, some things that you can try at home. I always encourage, continue to present new foods, continue to put it on the plate, and at least have your child being tolerant. And if your child is like throwing that food across the room, it's best to just not make a big deal of it and maybe clean it up later when they can't see you do it. But continue to expose them to new foods, even if they won't eat them. Now, of course, consider safety. So if you have a child that's, you know, at the sight of a new food is engaging in self-injury and you're worried about them hurting themselves, then that would be a good reason to seek professional help. Set your rules before you start. So if that's taking one bite of food, make sure that's clear up front and that it's not your child negotiating. If you put 3 bites of broccoli on the plate and they're saying, well, I'll do one, so make sure you start your rules up front. And I offer, if you have a child who's hungry in the morning, and there certainly are kids that are not and have no appetite in the morning, so consider that as well. But I think it's important to offer new foods in the morning. A lot of people will try, new foods at the end of the day, and I can't tell you how many kids I meet, and this is why we don't offer evening services, is because like the child has had breakfast, they've had snacks, they've had lunch, and I've had so many kids that are like, all right, I don't need to eat dinner. I'll wait till tomorrow morning. I'm going to get what I want again. So I think if you can capitalize on a time when your child should be really hungry, that's helpful. And for some kids, it is when they come home from school. So that's something to consider as well. Definitely set a meal and snack schedule and try and make it consistent as well. As I've said twice already, I mean, the grazing is something you really need to limit as much as possible. And then reserve a novel reinforcer, so something the child doesn't normally get to play with. And so if you are, you've negotiated and set your rule up front of, okay, 1 bite of broccoli is all you have to eat, and then you get to go on the swings in the backyard. Um, you know, make it something the child wouldn't normally have access to or something they wouldn't normally get to play with. That doesn't, in most cases, that doesn't mean you need to run out and buy things. We've had some kids who have done sticker charts and just loved earning stickers. We've had kids who in the clinic have earned like a badge for taking their bites. And I think it's really cool for the child that's motivated by attention because people walk up and they see them wearing their badge on their shirt and they go, oh, you took your bites. That's so cool. You ate a vegetable today. And that just helps the next meal where the child is thinking about, okay, I'm going to earn my badge and I'm going to get, a lot of people are going to talk to me and we're going to have fun. Um, Start small and increase. Be consistent. This is the biggest failure I see if treatment if meals fall apart after treatment's over, it's usually that the rules have been changed. Maybe the parent didn't even realize that they were changing the rules. But that's where we see things be problematic because the child is like, well, I've been taught that I only have to take 1 bite at a time of this food, and now you're telling me I have to take 3 bites or I have to eat my whole plate before I get to go play. And so that's where in the clinic we do follow-up appointments to kind of help plan for that and make it successful after discharge, and also so you're not doing the mealtime protocol for the rest of your child's life. Just some feeding programs that are out there in the world. These are kind of all the biggest. So obviously I'm from Healthy Beginnings and we have clinics in Columbia and Rockville. But the Kennedy Krieger Institute is the biggest and only inpatient program that I know of in the world. And then there's Children's Specialized Hospital in Somerset, New Jersey, which is a really great program. University of Nebraska is another really great program. Spark in Westchester, Pennsylvania. The Hershey Medical Center is offering feeding services they have for decades. And then the Marcus Autism Center in Atlanta, Georgia. All of these places have produced some really great research too. And so me as a behavior analyst and reading the literature and producing literature to contribute to our field and make the process more effective and easier and safer. These are all places that have contributed to that. And so from there, I'll give it back over to Dr. Stampone.
Thank you, Ben. That was awesome. Thank you so much for presenting really great content. I want to open this up to everybody for questions. If you have any, we have a little bit of time here. If you have any questions for Ben, feel free to type that into the Q&A box. You can find that at the bottom of your screen. And while you are typing in your questions, we are looking at July 9th, which is a Tuesday, for our next autism exploration. It is still in the works in terms of what our topic will be, but we have a really great presenter coming our way. So definitely mark your calendars for our next autism exploration. I'm excited for it. Okay, we have a question for you then. It
Grazing.
is,
Yeah, no, I see
yes.
it.
Oh, perfect. Okay.
Uh-huh. So, Nicole, grazing is when the child is eating like snacks pretty constantly throughout the day. I mean, maybe not all day, but it's like unlimited access to snacks or preferred foods that then so often that means that the child doesn't want to sit down for emails for meals because they don't have to and they can kind of play and eat what they want and go and play and come back and eat what they want and go and that just goes on and on and on. So that's disruptive to establishing, okay, this is mealtime. I want you to sit down and eat your plate of food. Yeah, if your child won't eat lunch in school due to temperature, I encounter this a lot as the example I gave that the thermos wasn't just wasn't keeping food warm enough. And I think what I so often recommend is feeding therapy to address that and work on accepting foods that maybe if you can't keep them hot enough that don't need to be hot. So if that's a sandwich, if your child won't eat um, any kind of like cold cuts or like peanut butter and jelly or sun butter and jelly, it'd be important to work on something like that you just don't have to worry about it being hot enough. That, or you could practice at home, um, working on foods at say dinner time that just aren't as warm as maybe your child would normally like. Something to consider there. Um, do we have to set time for meals? I guess I'm not entirely sure of your question. If you're thinking like a time limit, we usually aim for 30 minutes or less, is an appropriate amount of meal for a mealtime. But we have some kids that are just slower eaters and need like 45 minutes. I try and consider the time commitment of parents because I don't want parents to give up. So I usually aim for half an hour or less, or working towards that point so that the child is getting a sufficient amount of nutrition, of course. Um, Addressing food or sauce, so licking food or sauce, and not swallowing. So I think something you can do to address swallowing. So again, assuming your child doesn't have an issue, a medical issue with swallowing, then what I would recommend as far as a behavioral intervention goes would be offering some kind of reinforcement. So what we do is if we have a child that is like packing or holding food in their mouth or holding it on their tongue, or we have some kids that like hold liquids, which is amazing to me. But so when that happens, but so we offer some kind of reinforcer. So that's where I'll use like a kitchen timer. Or you can use your phone, but it is easier and less distracting for the parent if you have a like a kitchen timer that you set to 30 seconds. And when the child takes the bite is all the way in their mouth. Um, Set that timer. And if they have chewed and swallowed that bite within 30 seconds, they earn a reinforcer. So if that's, they get to play with the toy cars for 20 seconds and then they take the next bite. So you would take the toys, they would swallow the bite. You'd take the toy cars or play with the toy cars. After 20 seconds, take them away, present the next bite, and follow the same rule of if you chew and swallow in 30 seconds. Um, I hope I explained that in a not totally confusing way. One other thing you could consider with swallowing is reducing the size of the bite. So start with small bites. Lena, your son prefers, oh, great, thank you. Your son prefers having someone feed him instead of using utensils on his own, doesn't like getting his hands dirty. Um, so I definitely would, and this is where there is value in that kind of desensitization approach. I mean, again, that approach is not very effective at teaching children to actually eat new foods, but you can, if you can get your child, just kind of tolerate, touching even just for a few seconds, touching the banana or, kind of playing, you can do like play with shaving cream and like not even put the expectation out there of actually eating food because you wouldn't want to eat shaving cream. Um, but if he doesn't like getting his hands dirty, I mean, maybe you could work on like I know for some children we've done it where like the sandbox is like too big and intimidating, but we've done like a shoebox size thing of sand and like put toys or toy cars and things in there as a way to kind of get the child used to touching different textures or different feelings, which is kind of fun and cool. Um, but if you can also if you can teach him to use utensils, that sounds like a good option too if he's kind of looking for somebody to feed him. So there's a couple of things to consider there. Any other questions or any exciting things? Yeah, so that's hard. It depends on, without meeting your child, Mary, it depends on what the behavior looks like if she's refusing. And so that's where we really do, if it's a significant problem of, working on water or juice or fruit smoothies or Pediasure. If safety is a concern, if your child is prone to like flopping to the floor or any kind of self-injury or hitting others, that's where we really do value having the clinic setting to address those behaviors in a safe manner. And that's where those strategies come in. Um, that involve non-removal. So in the case of drinks, non-removal of the cup, where we would just kind of hold the cup and wait, but also offer reinforcement for when the child does take a drink. So if you were working on water, you could also start with a cup with like the tiniest amount, like maybe a quarter of an ounce. And when your child takes that little tiny drink of water, that entire quarter ounce, that's where you would offer a toy or get to play for 20 or 30 seconds as a way to reward that behavior of drinking milk or of water, sorry. Texture question, I was waiting for this. Okay. The consistency of crackers, so it has to have the same every time. Um, doesn't like fruits and vegetables that are crispy, squishy. Well, so I think this comes back to the strategies I've described of, really being able to reinforce eating and learning to tolerate new and different textures of foods. I mean, certainly I have tried to like oatmeal so many times and I don't like it. And so as a clinician where I judge, texture selectivity is if it's impacting nutrition, but also impacting, the ability of the child to leave the home or travel or to eat at school. And that's where we would look at more specific focused intervention in a feeding clinic. But teaching the child to be more tolerant. One thing I didn't mention in the presentation that is important is that we certainly have kids that come in and they don't eat any vegetables, and we don't expect the child to like every single vegetable or every food that we try in feeding therapy. And the same would be true with texture. But if it is a really narrow treatment or a narrow number of foods, that it is important to intervene. Sheena, we don't provide in-home AB or in-home feeding therapy with Verbal Beginnings. That's in part due to logistics of getting our therapists where they would need to go, and there's just not very many of us. But the other part of it is safety and having the controlled environment. Um, a lot of our kids that we meet have pretty significant refusal, and I'm really critical of clinicians who don't consider safety. And oftentimes at home, we can't consider or we can't guarantee the kind of safety that we need, which is why the clinic setting is important.
Okay. Well, that brings us to the 6 o'clock mark. And Ben, again, thank you so much for this wonderful presentation. And thank you, everybody, for submitting questions over to Ben. Back and forth is really helpful. Hopefully, everybody was able to have some takeaways from today's presentation. And we're very grateful for it. Thank you, Ben. So,
Yep.
hopefully, we'll see you at our next autism exploration. And I see lots of thank yous coming through, Ben. So, that's exciting. Obviously, everybody found this to be really great. All
Yeah, I
right,
mean, if
everybody.
if people are interested, we'll have to repeat the nutrition one from last year because
Yeah,
I just think it's such a fascinating topic, especially with autism and how nutrition is so important. So,
absolutely. Well, we got some spots open later this year, so maybe
okay.
we well might see Ben again, everybody. All right, well, everybody have a great rest of your evening and a good week, and we'll talk to you soon.
Thank
Bye
you.
bye.